Good morning. I have to say it's a little bit strange for me to stand up here on my own presenting on an interdisciplinary clinic because my work wife, Charlotte, is usually with me for these sorts of things, but she's agreed to answer all the questions, so that's great, isn't it? First, before we start, there are no particular disclosures from us, but we'd like to thank the Forum for having us again this year to present our work. And we'd also like to thank the Forum in particular for getting us away from the awful rain in the UK and to Perth. It's a wonderful city and we have certainly seen some of the sights, so thank you. So last year when we were here, Charlotte and I talked about some of the complexities and the challenges associated with managing secretion clearance and cough in people living with MND. Not least because cough changes and secretion issues are not usually the result of one primary issue. It may be a respiratory component, there may be a bulbar component, but there may be issues associated with cognition, neck flexion weakness, pseudobulbar effect, upper limb dysfunction, mobility. So the multifaceted nature of cough and secretion clearance in MND makes it very difficult. So 12 months on, after we presented some of the challenges, we set up a clinic known as the Interdisciplinary Cough and Secretion Clinic, very creative. And today we want to just introduce our clinic and talk through its use and some of the benefits of the model that we found for our patients living with MND. So I don't know whether this model is familiar to everybody here, but this is a model that we tend to follow in the UK, and it's a traditional model, and it's pretty much the model that we work with. And it's essentially a speech therapist that's based out in the community, that is often working alongside or in parallel to our community OT and physio. But our physiotherapist isn't necessarily trained in respiratory management. So our speech therapist who's managing bulbar impairment doesn't sit alongside our respiratory physio who is based in the hospital with our respiratory physician. And our secretion team, so our neurologist and maybe our clinical nurse specialists who are providing pharmaceutical prescriptions for saliva, are sat in a different clinic. So everybody's working in parallel and in silos. And when we work in silos, what we found when Charlotte and I started working together was that everything kind of got treated in silos. So our speech therapist would treat dysarthria and manage dysarthria. They would also manage the dysphagia symptoms. The physiotherapist in the hospital would look at cough function and manage weak cough. And the respiratory physician would be looking at the respiratory symptoms and hyperventilation and NIV. However, when you look at the symptoms of weak cough and dysphagia, what we found was there's quite a big overlap in the symptoms. And you have to tease those apart in order to treat them well. And if you look at the symptoms as a speech therapist, you probably would treat them as a speech therapist. And if you look at the symptoms as a respiratory physio, you would probably treat them as a respiratory physio. But they have quite different management plans and different types of assessment. So in terms of us looking at understanding the cause of our secretions and weak cough, we bring our skill sets together as a speech therapist and a physio to look at ultimately what's the etiology of the problem. Is it primary respiratory function? Is it a bulbar function? Actually, are the secretions a result of reflux? Are the secretions there because they're very dehydrated and we need to increase their hydration, hence those tenacious secretions might disappear? And once we've understood the root cause or the etiology of the secretion and the cough problems, we can then map on the appropriate treatment. So the management, as you can see, I'm not going to go through all of them, but the management options are really quite significant. And actually, as a speech therapist working alone before, I might only have turned to one or two of them. But as a team, we then have a whole plethora of options available to us. So in terms of shifting our model of working, what we are now encouraging is when our speech therapist comes in to look for bulbar or swallow or speech issues, we align that with what our physiotherapist is doing as well. So our respiratory physios out in the community or in the hospital looking for respiratory impairment and cough impairment, and our speech therapist is looking for a bulbar component. But what we do is we ask our speech therapist to measure cough peak flow, and we also ask our speech therapist to ask for symptoms of respiratory failure. Meanwhile, we also ask our respiratory physician or our physios in the community to look for any evidence of speech impairment, any at all, to the kind of naked ear. And if our physio is saying yes, there's indications of speech change, and if our speech therapist is saying yes, their peak flow is lower than 270, or it's lower than we would expect to see, or there are some symptoms reported of nocturnal hyperventilation, then we bring them into our interdisciplinary clinic to look at them together. So these are these guys here. So people showing evidence of bulbar and respiratory impairment, we try and look together. Those without any significant problems stay over here in the green for now, and the others might be managed via primary respiratory pathway or a primary bulbar pathway, depending on the nature of their problems. So the model essentially in our interdisciplinary clinic is interdisciplinary. It's a speech and language therapist and a physiotherapist. We work together in a contemporaneous manner. We offer quite a responsive service. We try and see our patients in the hospital clinic within 2 weeks. It's patient-centred. It looks at a full assessment and management, and it's one single contact of 90 minutes. The outcome is a comprehensive assessment tackling bulbar and respiratory issues from a physiotherapist and a speech and language therapist. It's immediate, so we make decisions together, and our knowledge builds our kind of theories and our assessments of these patients, and often our decisions change throughout the clinic appointment. We offer a range of multimodal treatments, so all of those options that were on the wheel before are available to our patients. We try and take them in a very logical manner, in terms of we don't throw everything at it at once. So our patient starts with one thing, and then we work through the rest of the wheel necessarily. It is bespoke and it's tailored, just like we heard this morning. It's all tailored to the individual sat in front of us. And we future plan in that clinic as well. So we try and arm our patients and our families for managing deterioration as well, so they don't have to keep coming back to see us every month or two. So the key questions we ask ourselves in that clinic is, what is the patient experience of their cough and their secretions? What is the priority to treat at this point rather than trying to treat everything? What's the least intrusive approach here? And how are we going to manage decline in the future? And the goals, of course, are to try and optimise quality and the comfort for the patient and minimise any burden that a weak cough or secretions are causing. So this is a lady we had in clinic just a couple of weeks ago. So this, just to give you an idea of how the sorts of patients that come through. This is a patient who's a 47-year-old lady. She was diagnosed with ALS at the end of 2018, and she was referred into our interdisciplinary clinic, having had a recent chest infection which needed 2 lots of antibiotics. And she was reporting actually her main problem was difficulty clearing sticky phlegm. Quite a common problem for any physios and speechies out there, you'll hear them say. She hadn't yet been assessed. She'd been assessed independently by a speech therapist and a physio out in our community teams, but she'd been prescribed carbamazepine, a drug to loosen secretions, by our respiratory physician. So that's how she arrived in clinic. Her ALS FRS was 17. She was still mobile, but using a wheelchair for longer distances outside the home. A brook upper limb of 6. Her weight was reasonable. She started to lose 1 kilogram or 2 over the last few weeks. Her functional oral intake scale, for the non-speech therapists out there, is a scale describing how well they're eating and drinking and whether they're on modified diet and fluids. This lady was taking pureed meals in the evenings because of fatigue, and occasionally thickening her fluids when she was tired as well. So if you look at her bulbar function scale, you can see that her kind of self-reported problems were more related to speech and swallowing rather than saliva management. She wasn't on NIV. We measured her peak cough flow, which was 160, a voluntary cough of 160, which is way below what we would like to see, so below 270. So the patient came to clinic and her aims were having a strategy to clear the sticky phlegm and have a plan for the chest infection. She'd already had one and she wanted a plan for the chest infections over the UK winter. So when we clinically assessed her as a speech therapist and physio, we found that she had an incredibly mild mixed dysarthria. So the first port of call was getting into a voice banking clinic before the voice and the speech deteriorated. There were no drooling or saliva management issues. She was eating and drinking with a little bit of adaptation, but she had great difficulty generating a voluntary cough. Her reflexive cough, however, was pretty good. And she also complained of a dry mouth and a horrible taste in her mouth. So we wanted to assess the cause of her phlegm, the sticky phlegm, before we tried to treat it, because we wanted to understand why it was there in the first place. And then we wanted to identify an appropriate cough augmentation and a chest management plan. And we did that using a secretion rating scale. We used the reflux severity index score because we had a suspicion that her phlegm might be reflux related. We used a nasendoscopy, so a small camera in the nose that looked down into the throat to have a look at the secretions. And we also did a respiratory assessment, so we did her blood gases and her spirometry in that clinic as well because she hadn't yet had the full respiratory workup. And her treatment plan, essentially, we diagnosed that actually the primary cause of her thick secretions was reflux, so the acid. And actually, if we treated the reflux, she may not be experiencing those symptoms. So she was prescribed a course of anti-reflux or proton pump inhibitors. We also prescribed some thrush or candida prescription because she had oral bacteria on her tongue, which explained the dryness and the nasty taste in her mouth. And at that point, we referred her to gastroenterology for an early gastrostomy because while she wasn't really losing weight, we felt that hydration was a big issue for this lady, hence why some of her secretions were so thick and tenacious. We wanted a gastrostomy. She was okay with that purely for hydration at this point. And we stopped this carbocisteine because there wasn't a need for it in this lady because the primary cause was actually reflux and dehydration. This lady, because her peak flow is 160, we did try a cough assist because we thought in future this lady might need a cough assist. It might help clear secretions in the future and guard against infection. And she tolerated it quite well. So she took that home too for a trial. But we focused on the priority treatments, which were the reflux, the thrush treatment, and referring for hydration at this point. In terms of priorities for treatment, it can feel a little bit overwhelming in the clinic because it feels sometimes that everything needs looking at, but we have to look at what is the priority problem here. And these are the kind of things that we come across. So uncontrolled saliva, a weak cough, dysphagia, chest infections, sticky phlegm, and stridor. And if, for example, our patient comes in complaining of a weak cough, that's their primary problem, we would first of all look at the cause of the cough symptoms, what's causing the symptoms. Are they respiratory or are they bulbar issues that we're looking at? Are the issues with the voluntary cough or the reflexive cough? Is this a result of an acute or chronic respiratory infection? And what's the mobility and the activity of this person? And once we've decided that, we would look at the appropriate management for that person. Similarly, if the person has got sticky phlegm, we would look at hydration, reflux, throat weakness, and whether the phlegm truly is a result of a weak cough or not. And then we would map on our treatment. So it might be gastrostomy at this point. Seems a big leap, doesn't it, from sticky phlegm to go straight to gastrostomy, but if you follow the logic, it kind of makes sense. And that's the examples that we use for our patients. So in terms of clinical outcomes, we've seen 59 patients through our clinic this year. We've crossed out 59 because not all of them had motor neuron disease. 28 had motor neuron disease. The others were other neuromuscular conditions. And as you can see here, the predominant issues were saliva and weak cough, as well as some swallowing issues and some history of chest infections. So a bit of a mixed bag, really. The interdisciplinary management side, out of those patients that we've seen, only 5 were clinically indicated a nasendoscopy. And you can see here why we'd use it. We might be looking for silent aspiration as a cause of chest infections. We might be using it, for example, to set up a cough assist or NIV to manage the bulbar response to airflow going through the throat. And these are the altered management programs that we've put in place for our patients. So of all the patients we've seen, only 1 we haven't changed anything for. And in some cases, the actual management isn't giving the patient anything. It might be taking something away. And because you've got a speech therapist and a physio in the same room, of course you end up doing other things as well, don't you? So the other things you end up prescribing, saliva gels, neck collars, voice banking, humidification, chin straps, things we've heard about this morning because you've got 2 professionals sat in the room and we try and troubleshoot while we're there. And in terms of patient satisfaction, there's a lot of words on that slide, but essentially our patients are kind of the best assessors of this service, and we've had a really great response rate from our patients, and I think it was something like 97% of patients would recommend this clinic to other users, and they felt that it met their needs in a one-stop service. And this is one of our wonderful patients here. So these are some of their quotes. I think it was some really lovely quotes from our patients, and we haven't paid them, I promise. They said the service was really informative and useful, and they said, for us, the fact that it was sensitive to their needs and bespoke without any intrusive testing as necessary, and the fact that they felt that we'd taken the time to go through everything in a logical manner and make it feel a bit more straightforward with logical steps, made us feel like we were doing the right thing by our patients. We're still in the process of assessing and evaluating the service. But in terms of recommendations from what we've done this year, we know that the cough and secretion management is complex because it's multifaceted, and it does require quite a comprehensive and an interdisciplinary approach. We found that so far our model allows contemporaneous, responsive and bespoke patient management programs. And so far it has demonstrated patient satisfaction, efficiency and quality care. Thank you very much for listening.
Thank you, Jodi, for that presentation. Does anybody have any questions for Jodi? You must have answered it all perfectly. Anything at all? Yeah, we've got one over here.
Hello. Hello. There I am. You're talking about seeing them for their 90-minute period and then going home with medication for thrush and reflux and something else that I wrote down. How do you go about accessing prescriptions and things when you've got physio and or can you prescribe those?
Yeah, so we the clinic has, the nice thing about the clinic is that it's overseen by a respiratory consultant who can do the prescribing for us. We also have access to a consultant MND nurse who can provide Botox treatments and prescriptions for all the anticholinergics as well. So that's where we get our prescriptions from. For patients who live a lot further away, we might write to the GP or email the GP surgery that day so the patient can pick up a prescription on their way home.
Okay, one more just here.
Thank you for your presentation. I just have a question in the area of, I suppose I'm supposed to be supporting my respiratory nurse colleagues. In relation to use of saline nebulisers, it's sort of in our bag of first aid tricks for sticky phlegm, but I sort of have learnt today that there might be another way of looking at saliva and secretion management. So what was your use of that in your repertoire with your respiratory physio?
I mean, this is probably one that Charlotte would want to chip in on, but often we find patients come to our clinic with a prescription of saline nebulisers, because that's almost one of the go-to kind of managements. And certainly in my experience as a speech therapist, what I find is because they're wet, some of our patients with dysphagia don't enjoy them particularly much, so or don't enjoy them too much, so we look at other options like simple steam inhalation that they can do over the shower or over a steam mug, or just generally looking at how we can increase their hydration. Either we might refer back to the dietitian to look at PEG regimes, to look at actual systemic hydration as well. So it's something we certainly use, and it comes back down to the individual, doesn't it? If the patient likes it, great. We're never going to suggest taking that away, but we just look, it's about expanding the toolkit, really.
I just have one comment. It's just a case comment. I'm working with a MND person with frontal temporal dementia and seems to be relieved by saline nebulizers. It's the only treatment that he'll allow to happen. So it's just a comment, really. Yeah,
absolutely. And I think one thing that is always, now we understand a lot more about cognition and apathy as well with these guys. We have to go with what works. So
That's great. Lovely. Thank you very much, Jodi.
Thank you.